Okay, so in this lecture we talked about water balance, we talked about electrolyte balance, we talked a little bit about acid-base balance, and we started by talking about total body water. So this is just the sum of all of the fluids or the water in the body. And total body water is divided into intracellular fluid and extracellular fluid. Now, intracellular fluid, this is found inside cells, and that's the majority of body water, about 67%. Extracellular fluid, this is found outside of cells, okay? And this includes interstitial fluid, which is the fluid between cells, and the intravascular fluid, which is basically just plasma. Alright, then we talked about the movement of water between compartments. So osmosis, this is just the diffusion of water across a semi-permeable membrane like the cell membrane. And this is basically regulated by the concentration of particles that do not or cannot diffuse. Alright, so if you have more stuff in one compartment, water is going to move that compartment to try to dilute it. Now, fluid also moves between the extracellular compartments, so basically between the blood and the interstitial space, okay, the capillaries and the interstitial space. And there are two main forces that dictate which way water moves. You have hydrostatic forces, which push fluid. This is basically what happens for filtration. And you have the osmotic or oncotic forces, which pull fluid. Okay, and albumin, of course, is very important for that, which we'll talk about. So let's just review these really quickly. So we had 4 of these forces. All right. So this is our capillary. And the first one was capillary hydrostatic pressure. Okay. And this is the force that is pushing water out of the capillary and into the interstitial space. Okay? So things like blood pressure or increased venous pressure, anything that increases pressure in the capillaries will increase capillary hydrostatic pressure. Okay? Then we had capillary oncotic pressure. And this is the pressure that pulls fluid into the capillary. Okay? So plasma proteins like albumin are really, really important for increasing capillary oncotic pressure. Albumin is important for keeping water in the capillaries and keeping water from leaving. Okay. Then we had the interstitial components. So we had interstitial hydrostatic pressure. Okay. This is the force that pushes fluid from the interstitial space into the capillary. Okay. And then finally we had interstitial oncotic pressure. Okay, and this is the force that pulls water into the interstitial space from the capillaries. Okay. And this just is kind of a prettier picture of all of this. So again, capillary hydrostatic pressure, this is a filtration force. It's the pressure that's pushing water into the interstitial space. Okay. Interstitial oncotic pressure, this is pulling water in that same direction. Okay, so it's the force that pulls water from the capillary into the interstitial space. Interstitial hydrostatic pressure, this is the force that is pushing water into the capillary. And then capillary oncotic pressure, this is the force that is pulling water into the capillary. Okay, so again, hydrostatic pressures and forces, they push. Oncotic pressures pull. And again, this is a capillary, so we have the arterial end of the capillary, and then we have the venous end of a capillary. Most of this fluid that ends up out here is going to be reabsorbed on the venous end of the capillary, but whatever is not reabsorbed will enter the lymphatics. Okay, that's the job of the lymphatic system, is to pick up this fluid, which is basically just plasma with some white blood cells and stuff in it, and then return it to the bloodstream. Of course, it filters it through lymph nodes and all of that stuff too, but that's the main job of the lymphatic system. Okay, then we talked about fluid regulation as far as intake. So we have receptors in the hypothalamus called osmoreceptors, and they are going to be stimulated by dehydration of cells, by decreases in blood volume or blood pressure, and a couple of other things. Now, there are 3 really important hormones that are involved with fluid regulation: angiotensin II, aldosterone, and antidiuretic hormone. All right, and we talked about the renin-angiotensin-aldosterone system, so let's run through that again. Okay. So this is going to be our blood stream here. All right. So our journey is going to start in the kidneys. Okay. And in the kidneys, we have these cells called JG cells. Okay. And they sense drops in blood pressure. Okay. And when they do that, they're going to release an enzyme / hormone into the blood called renin. Okay. Now, our next organ here in our little journey is the liver. Okay. Now, the liver is going to release an inactive enzyme into the blood called angiotensinogen. Okay. And angiotensinogen is going to meet renin in the blood. Okay. And when they do that, renin is going to basically cleave this off. Remember, when you see that ending inogen, it means inactive. So renin is going to cleave angiotensinogen, and that's going to produce angiotensin 1. Okay. Now, our next organ here, got a pair of lungs. All right. And the lungs are going to produce an enzyme called ACE. Angiotensin converting enzyme. Okay. An angiotensin converting enzyme is going to convert angiotensin 1 into angiotensin 2. We'll just call it A2. Okay. Now, angiotensin 2 is going to have a number of important jobs. Okay. So here's another sickly looking kidney. But one of its jobs is to go to the adrenal cortex and stimulate the release of aldosterone from the adrenal cortex. Okay, and aldosterone is very important for electrolyte and water balance. So let's just go through. I'll write these down here. So angiotensin 2. Okay. So by itself, it is a potent vasoconstrictor. Okay. We know that it stimulates the release of aldosterone. It also stimulates the release of antidiuretic hormone, ADH, also known as vasopressin. Okay. Now, let's put aldosterone over here, and we'll talk about what aldosterone does. Aldosterone stimulates the reabsorption of sodium. So it tells the body to keep sodium. It also tells the body to secrete or get rid of potassium. Okay? And if we keep sodium, we keep water, and we increase blood volume and increase blood pressure. That's the whole job of this system, is to increase blood pressure. All right. Now, antidiuretic hormone, ADH, also known as vasopressin, this is actually produced in the hypothalamus, and then it's stored and released from the posterior pituitary. Its job is just to conserve water. Okay, it tells the kidneys to conserve water. Keep water. And again, if we keep water, we increase blood volume, we increase blood pressure. Okay? So, basically for exams purposes, you need to know where everything's coming from. You need to know what they do. And you need to know their function. Okay? So basically everything I've run through on here, you need to know. Okay. Okay, and this is just the words that go through everything that was in the picture. Again, this is just kind of another pretty picture. Couple of things here. So natriuretic peptides, these are hormones that are produced from the heart, from the atria, and they kind of inhibit this RAS system. They don't do it very well, but they do counteract it a little bit. Okay, so tonicity, we reviewed this in class. If you have an isotonic alteration or an isotonic solution, that means the concentration of stuff outside of the cell is the same as the concentration inside. Therefore, you have no net movement of water. Okay? In a hypertonic alteration, the concentration outside the cell is greater than the concentration inside the cell. Therefore, water is going to move out and the cell will shrink. And in a hypotonic alteration, the concentration is greater on the inside of the cell than the outside, so water moves in. Okay, then we talked about altered fluid balance, starting with hypovolemia. So this is just low fluid volume. Can be due to hemorrhage or excessive sweating, not drinking enough water, or if you have a shift of fluid to a third space, which occurs in edema. Clinical manifestations, things like thirst and decreased urine output, dry mucous membranes, drops in blood pressure, and with that, increases in heart rate. So dehydration, this is when you have decreased extracellular fluid volume or increased sodium in relation to water. Okay, so cause of this, obviously things like diarrhea, sweating, vomiting, hyperventilation, because when you exhale water, or just not drinking enough water. Water intoxication, most commonly caused by drinking too much water after strenuous exercise, but also the use of diuretics can result in this. Okay, then we talked about edema. So this is excessive accumulation of fluid in the interstitial space. So that's an important part. This is fluid that's accumulating in the interstitial space, not inside the cells. Now, this can be due to a number of factors, one being capillary hydrostatic pressure increases or decreases in capillary oncotic pressure, obstruction of the lymphatics, that's called lymphedema, or increased capillary permeability, which we see in inflammation. So capillary hydrostatic pressure, increases oftentimes due to increased venous pressure. So if you have increased venous pressure, which occurs in things like DVT or cirrhosis or standing, that increases capillary hydrostatic pressure. And I'll explain that more when I talk about cirrhosis. Or if you're retaining salt, that's going to result in water retention also, which increases blood volume, and that's going to increase your capillary hydrostatic pressure. Okay, so these are all associated with salt and water retention. We will talk about these. We'll talk about liver disease today, but we'll talk about CHF and renal failure down the road. Now, liver disease results in decreased albumin production because albumin is produced by the liver. Liver is really important for increasing capillary oncotic pressure, so if it's not there, this perpetuates edema. Any loss of plasma proteins will decrease oncotic pressure and be a factor in the formation of edema. Like I said, increased capillary permeability occurs in inflammation. And then lymphedema, this is caused by damage or removal of lymphatic vessels. So this could be due to, things like tumors or radiation or removal. I use the example of a unilateral mastectomy. You can really see lymphedema in those cases. So the clinical manifestations of edema, generalized or localized swelling, dependent edema, you see this in areas that are susceptible to gravity, depending on your position. So obviously the legs and feet if you are upright, or like the sacral area if you are supine. Pitting edema, you see this more so with diseases of vital organs. Non-pitting edema, this is, lymphedema, mixed edema. And those aren't always, the case, but just in general. And then treatment, elevation, compression. If it's really, really severe, administer albumin, and obviously treatment of any underlying causes. So, edema. So here are the forces that kind of cause edema to happen. So if you increase hydrostatic pressure, so you increase venous pressure, this causes fluid to move out into the interstitial space. If you have decreased oncotic pressure, you don't have enough stuff pulling that fluid back in, so it just hangs out in the interstitial space. Increased permeability, again, this occurs in cases of inflammation. We know that edema is a cardinal sign of inflammation. And also lymphatic obstruction. So in this case, it's a tumor obstructing the lymphatics. All of that excess fluid cannot be picked up by the lymphatic system. Okay, so then we talked about cirrhosis. So this is a chronic liver disease, and basically what happens here is you replace the functional tissue of the liver, parenchyma is the functional tissue, the hepatocytes, with scar tissue, and that really interferes with blood flow. Okay, most common causes chronic alcoholism and hepatitis C, but also things like heart failure, specifically right-sided heart failure because of the congestion in the venous system, but also obstruction of the bile duct. So this scar tissue is laid down by these cells called stellate cells, which are basically fibroblasts. They just make fibers. But the big problem is the obstruction of blood flow, which just continues to decrease the function of the liver. So clinical manifestations, abdominal pain, loss of appetite, you'll see jaundice, easy bruising, GI upset, a number of things. Now a late manifestation is ascites, okay, along with compromised organs of basically every other system. And I will show on a couple slides how ascites actually forms, okay. So diagnosis, liver biopsy is confirmative, imaging, CT scans, MRI, and blood testing to check liver function. So as far as treatment, diuretics, paracentesis to try to remove fluid, shunts to divert blood from the portal vein, which I'll show why that's important in a second, and also nutritional supplementation because they're quite compromised nutritionally. So again, cirrhosis. This is just showing paracentesis. There's a couple of different ways you can do it. You can go ventrally, you can go laterally. But anyway, I want to just kind of demonstrate how ascites happens. So ascites, of course, is the edema of the abdominal cavity. So this is the liver. The big vein that goes into the liver is called the portal vein. And the portal vein will accept all of these other veins. Okay? And these are the veins that are coming from the digestive organs. Okay? And, further down in the actual organs, we have the capillary beds. So with all of this scar tissue up here, all of this blood just keeps backing up and backing up and backing up, and it backs up into capillaries that would be down here. So when that happens, that increases capillary hydrostatic pressure. So that pushes fluid out into this space here. All right? Now, on top of that, the liver is also not producing albumin. So if you're not producing albumin, you will have decreased capillary oncotic pressure, so you don't have forces keeping fluid in the capillaries. So it's kind of a double whammy. Not only do you have increased capillary hydrostatic pressure, but also decreased capillary oncotic pressure. And those are two big drivers for edema, and in this case, ascites. Okay, so then we talked about electrolytes, basically things that when you dissolve them in water, they conduct electricity. Sodium is the most abundant cation in the body, and of course we find this in high concentration in the extracellular fluid outside of the cell. Chloride is also found in highest concentration outside of the cell, and it's the most abundant negative ion, or anion, and that's because it just moves passively with sodium. So this is just showing, where these major ions are located. So sodium, of course, high concentration outside the cell. Potassium, high concentration inside the cell. Chloride, high concentration outside. Calcium, high concentration outside. Bicarb, high concentration outside. So you can see how some of these are organized. Alright, then we talked about hyponatremia, which is when you have low levels of sodium, specifically less than 135 milliequivalents per liter, and that's in the blood. And this can be due to an increase of water, which we'll talk about how that can happen later in the class, but also a decrease in sodium. So common causes: sweating, vomiting, diarrhea, and basically when you lose that extra sodium outside of the cell, water is going to move into the cell, okay, and the cells will swell up. So clinical manifestations, some important ones here: hypotension because of the loss of blood volume, tachycardia, oliguria. Those are pretty important clinical manifestations, but you definitely will see nausea, vomiting, lethargy, confusion as it worsens. So again, this is showing hyponatremia, which is a hypotonic alteration. You have less sodium out here, so water is going to move into the cell, and the cells will swell. Okay, so hypernatremia, this is when you have too high of sodium, greater than 145 milliequivalents per liter in the blood. And this usually results in hyperchloremia because we know that chloride tends to move passively with sodium. Okay, and this can be due to an increase in sodium or decrease of water. So if you consume too much sodium in the diet, that's a common cause. There are certainly other causes, but water is going to move to the extracellular space, and this dehydrates cells. So this is a hypertonic alteration. So important clinical manifestations here: thirst, weight gain, increased blood pressure, bounding pulse. Again, the weight gain is due to the fluid. You're holding on to fluid in the blood, and increased blood pressure because of the increased volume. So again, this is hypernatremia. This is a hypertonic alteration. So you have a higher concentration of sodium out here. Water moves out to try to dilute it. So conditions associated with hypernatremia, we are going to talk about these specifically when we come to them, and we will bring this back up. So don't worry about this too much now. Just know that these topics are going to apply as we learn about more and more diseases. But I want to point out that tachypnea, increased respiratory rate, can cause hypernatremia because of the loss of water. And then again, conditions associated with hyponatremia. So SIADH, we'll talk about that specifically, and basically this causes a type of hyponatremia known as dilutional hyponatremia. Hypothyroidism, CHF, liver cirrhosis, which we talked about, all associated with hyponatremia. Okay, so potassium, the most abundant intracellular cation, very, very important. Also important to note is that changes in pH affect potassium levels. So basically, if somebody is acidotic, okay, we'll say this is a cell, somebody's in acidosis, what happens is acid, H+, think of it as H+, moves into the cell. All right, we know that potassium is in high concentration in the cell. So when you have more positives coming in, potassium leaves. Okay, so potassium is going to leave in order to maintain electroneutrality, maintain balance. Okay, so that's an important point. And basically that can cause hyperkalemia. Now, let's talk about hypokalemia really quickly. So this is when concentrations of potassium in the blood are less than 3.5 milliequivalents per liter. You see this with vomiting, diarrhea, also diuretics, pretty common causes. So hyperkalemia, serum levels greater than 5.5 milliequivalents per liter. Actually pretty rare because the kidneys are very good at secreting potassium into the urine. So if this happens, it's typically due to mismanagement of medications. Now, like I just said, movement of potassium from the intracellular to the extracellular space can cause hyperkalemia. So again, that's just the acidosis case. So if somebody is in acidosis and you have the movement of these hydrogen ions to the inside of the cell, potassium will move out to maintain what in the world? To maintain electroneutrality. Let me fix that. So potassium is going to move out, and again that will cause hyperkalemia. And that also has effects on chloride and bicarb also. Okay, so calcium. Calcium is controlled mostly by parathyroid hormone, which comes from the parathyroid glands, but also vitamin D. Vitamin D is very important. And basically the job of both parathyroid hormone and vitamin D is to increase the amount of calcium in the blood, increase serum calcium levels. Calcitonin's job is actually to take calcium from the blood and put it back into the bones, but it's really not that important of a hormone. Now, calcium, we need it for our bones and our teeth, but we also need it to communicate between neurons. We need it to clot our blood. We need it for smooth muscle contractions. We need it for skeletal muscle contractions. Calcium is very important, okay? And it's kept in very, very low concentrations inside the cell. Outside the cell, or in the blood, we find it between 8.5 and 10.5 milligrams per deciliter. Hypocalcemia, neuromuscular excitability. So I talked about Trousseau's sign and things like that. It causes neuromuscular excitability, and that's because calcium actually increases the gap between resting potential and threshold. I will talk about that more when we talk about the nervous system. Okay, so neuromuscular excitability, tetany, which is basically involuntary muscle contraction, sometimes to the point of paralysis. And cardiac arrest can occur in both hypocalcemia and hypercalcemia. Okay. Causes of hypocalcemia, things like hypoparathyroidism. So if you don't produce enough parathyroid hormone, you can expect hypocalcemia. Also, insufficient intake, or maybe a lack of vitamin D. If you don't have enough vitamin D, you're not absorbing calcium in the gut. So those are just a couple of more common causes. Hypercalcemia, nausea, constipation, and nephrolithiasis. So definitely constipation, definitely nephrolithiasis. Dysrhythmias, bradycardia, cardiac arrest, definitely associated with cardiovascular issues. Causes of hypercalcemia, things like hyperparathyroidism. So if you produce too much parathyroid hormone, that can certainly cause hypercalcemia. Also, too much vitamin D. So if you have an excess of vitamin D, that can cause hypercalcemia. Vitamin D is believed to be the most toxic of the vitamins. Okay, so those are just a couple of causes. So magnesium, very important cation, especially in the cell, but serum value 1.8 to 3 milliequivalents per liter. Its main, I don't want to say its main job, but one of its most important jobs is to be a cofactor for energy producing and energy using reactions, which are pretty much all of them. Magnesium is very important for reactions that use ATP. Now, magnesium increases neuromuscular excitability. That's an important point, and you'll see that when we talk about hypermagnesemia. So, hypomagnesemia, muscle cramping, irritability, hypotension is common, but muscle cramping is definitely one to remember. So, causes of hypomagnesemia, these would be things like malabsorption, so you're not absorbing the magnesium, and a couple of others. Okay. Now, hypermagnesemia results in excess nerve function. So you'll see things like overstimulation of muscles to the point where they're weak. You'll see things like diarrhea, and causes of hypermagnesemia, things like renal failure is a pretty common cause. You see it a lot with renal failure. Okay. Also, sometimes people will consume too many antacids that contain magnesium, or they oversupplement just magnesium by itself, and that can certainly result in hypermagnesemia. Okay, then we talked about acid-base balance. We know acid-base balance is tightly regulated. pH stays between 7.35 to 7.45, and we're able to keep it there because of buffer systems. Okay, so buffer systems are just these systems that resist changes in pH. And they do that because they're typically a mixture of a weak acid and a weak base. Okay, and I'll kind of show that in a little bit how that works and why that's important. So our first line of defense when it comes to buffering is phosphate and proteins. These are negatively charged. We find them outside the cell, but also inside the cell. So they're really important interests. They're probably the most important buffer system inside cells. Okay, and the reason is since they're negatively charged. Okay, so for example, phosphate, PO4 minus, since it's negatively charged, if you have an influx of, H plus ions, which you would see in acidosis, into the cell, this can kind of suck it up, okay, and can kind of neutralize this. So that's why it's such an important intracellular buffer. Proteins really do the same thing. Okay, so probably the major buffer system in the body is the carbonic acid bicarbonate buffer system. and this includes both functions in the lungs and the kidneys. So the lungs are really the second line of defense because they can change how much carbonic acid is being kept in the body or being excreted from the body through respiration. Okay, so if you blow off more CO2, pH is going to go up. You're blowing off acid. If you have deep, slow respirations, you're going to or just slow respiration, you're going to keep more CO2. pH will go down. Now the kidneys are very important because they can do a whole bunch of stuff. Okay, they can reabsorb bicarbonate, which is a base. They can make new bicarbonate with water and CO2. They can secrete hydrogen ions, acid. So they can do a lot of things. Kidneys are very important. They're the third line of defense. Now at normal pH 7.4, there's a 20-to-1 ratio of bicarb to CO2, or bicarb to carbonic acid. Okay, CO2, really its acidic form is carbonic acid. Okay, and then compensation, this occurs through either respiratory changes or urine changes. I'll talk about that in a second. So this is just showing that at normal pH 7.4, 20 parts bicarb to 1 part carbonic acid. So a couple other ones here. Proteins, like I said, proteins are negatively charged, so they can attract those H+ ions. Really important. So they're kind of just like a passive buffer. They're just there, and they can buffer very well. So for example, hemoglobin can act as a weak base, and then it can bind with H+, make it a weak acid, so it can kind of go both ways. And can also bind CO2, which, think of that as an acid. And like I said, the kidneys are very important because they can secrete hydrogens, they can reabsorb bicarb, they can make new bicarb, they can excrete bicarb, they can do it all. Now down here, would secreting H+ ions into the urine increase or decrease pH? So if you are secreting H+ ions in the urine, okay, you're acidifying the urine, that's going to cause pH to go up. It's going to alkalize the pH. So we're going to talk about this system in more detail when we talk about the respiratory system, but I just want to go through it really quickly right now. Okay, you don't need to worry about these details, but I just want to kind of paint the picture. So in our tissues, our cells produce CO2. Okay, CO2. CO2 enters the blood. All right, some of it's dissolved in plasma, some of it is bound to hemoglobin, but 70% of it will actually enter red blood cells and undergo this reaction that, along with water, will form carbonic acid and bicarb. Bicarb, remember buffer systems, weak acids and weak bases. Bicarb is the weak base, carbonic acid is the weak acid. And that's what makes them so good, because HCO3 minus, say you have you have some acid, H+. Bicarb can kind of neutralize that, okay, and it will actually become H2CO3. Now, the same thing with H2CO3, carbonic acid. If the body is, alkalizing, if it's becoming more basic, H2CO3, carbonic acid, can get rid of these hydrogen ions, and then it will become bicarb. So that's how a buffer system works. Okay, really important buffer system. There's some other things that are going on that we'll talk about later, but basically, once this gets back to the lungs, once this red blood cell, this reaction actually reverses. CO2 is released from that red blood cell, and you exhale it. Okay, so really important buffer system. Don't worry about the details now because we're going to learn the details later. Okay, so acid-base imbalances. You obtain these values through ABGs, and acidosis. This is just when pH drops below 7.35. And this is either due to a decrease in bicarb or an increase in acid or hydrogen ion concentration. Alkalosis, this is when pH is above 7.45, and it may be due to an increase in bicarb or a decrease in hydrogen ion concentration. And of course, these can be either metabolic or respiratory. So metabolic acidosis, due to an increase in non-carbonic acids. That's really key, non-carbonic acids. We're not talking about the lungs, we're talking about a metabolic acidosis. Or a loss of bicarb, as well as the possible inability for the kidneys to make new bicarb. Okay, which can happen in renal failure. So lactic acidosis, diabetic ketoacidosis, those are a couple of really common causes. We'll talk about diabetic ketoacidosis in detail when we get to the endocrine system. Lactic acidosis can arise by a number of different conditions and situations. Metabolic alkalosis, typically due to the loss of metabolic acids, okay, and then you have an increase in bicarb. So an example here, hyperaldosteronism results in the retention of sodium bicarbonate. Okay, so if you retain bicarbonate, obviously that's a base, pH will go up, as well as diuretic use can cause metabolic alkalosis. Okay. Even vomiting sometimes when you lose that stomach acid can result in metabolic alkalosis as well. Okay, respiratory acidosis. This is typically due to hypoventilation, some sort of depression of respiration. So maybe damage to the medulla and the brainstem, or maybe something like the restrictive lung diseases like emphysema and pneumonia. Well, not pneumonia, but emphysema, asthma. But pneumonia can certainly cause respiratory acidosis. Pulmonary edema, which you see in left-sided heart failure. So yeah, basically just depression of respiration in some way. Anything that allows CO2 to stay in the body, okay, is going to cause respiratory acidosis, okay, from the lungs. Now, respiratory alkalosis, this is typically due to deep, rapid respiration or hyperventilation. You see this in sepsis and CHF and cirrhosis, but basically you're blowing off too much CO2, and that's going to cause pH to go up. Now, this term hypercapnia, that refers to too much CO2 in the blood. Hypocapnia, too little CO2 in the blood. So I just want to point out those terms. Okay, so this is kind of a flow chart showing all the things we talked about. Acidemia, this just refers to acids in the blood. It doesn't say anything about whether or not acidosis. It just is, saying that there are acids in the blood. Same thing with alkalemia. Once you get to acidosis, that's when you drop below 7.35. And same thing with alkalosis. That's when you get above 7.45. Now, I do want to point this out. When somebody has a respiratory problem, whether it's acidosis or alkalosis, you compensate with the kidneys. If you have a metabolic problem, you compensate with the lungs. Again, respiratory problem, you compensate with the kidneys. Metabolic problem, compensate with the lungs. That's why people who have diabetic ketoacidosis, a type of metabolic acidosis, that's why they hyperventilate. Okay, they have those characteristic respirations because they're trying to blow off acid. Okay, you're compensating with the lungs. Okay, as always, if you have any questions, please let me know.